David, don't you think it's time that we deal with America's unhealthy addiction to over-prescribing?
Well, John, I don't think, but we have a MacArthur Foundation Genius Award winner, Dr. Eric Coleman, who's here today to talk to us about de-prescribing.
As long as it's not you.
Welcome to CareTalk, your weekly home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix.
Hey, John, I'm tired of listening to you all the time, so we brought an actual certified genius onto the show. Who we got here, John?
We have our old friend, Dr. Eric Coleman, who is the director of the Care Transitions program, but in many ways was the inspiration and founder of the art of care transitions. He's also a MacArthur Genius Award-winning geriatrician. I think it's there may be other MacArthur Award winners, but he's the only geriatrician, and in recent years, are the only doc who's won it. And he's also a special advisor and in many ways has inspired a lot of the work we do at CareCentrix. Welcome, Dr. Coleman.
Thank you to you both. I'm eager to get started.
Well, good. We were going to have a stable genius on, but we're going to have to settle for a regular genius here, stable or not. So, Eric, listen, one question. You have this concept I've heard about de-prescribing. As the baby boomers are getting older, there's this concept you mentioned, de-prescribing. That's kind of like when they were deprogrammed from the cults back in the 60s. What are we talking about de-prescribing?
Very good. Well, I cannot say that I came up with this idea, but I do care very deeply about it. I think if we sort of look at the way an older person, for example, gets home and looks into their medicine cabinet, and you ask the question, how did they get there? There is so much energy on the prescribing side of things, but so little energy sort of reevaluating at particular checkpoints. This is a topic that makes people nervous. It makes payers nervous because they're afraid if they start nodding their heads affirmatively, it looks like it's being driven by financial gain. It makes specialists nervous because when you send somebody to refer someone to a specialist, they feel like they need to do something. In some cases, there's not an obvious next step, and so a prescription kind of fills that void. And there's a very strange sort of dynamic among prescribers that it's somehow taboo to take one of their medications away, that you're somehow not respecting their decision. And so what this means is you have add, and very little subtract. And, meanwhile, 12 plus years ago, Joint Commission steps in and starts banging the drum for medication reconciliation. 12 years later, what have we learned? Is the delivery system safer? No one has actually spoken of the fact that we haven't evaluated whether having mandated medication reconciliation makes any sense. And that sort of brings us to what I would consider sort of the magic moment of de-prescribing, which is we keep reconciling the medication list that's in the electronic health record, which often bears very little resemblance to the medication list that the patient actually takes. And so lesson number one is we obviously have to gain trust and cooperation of the patient to actually share the list of what they're taking, which is not as easy as it sounds. And second, this has to be a two-way street. We have to realize that it can't just be professional telling patient what to do. There really needs to be more of a dialogue. And we see very little of this anywhere in the delivery system, with the exception of hospice. So the irony is you finally get someone to take a hard look at your meds when you've enrolled in hospice.
So Eric, just contextually here, I think that the number of monthly medications that adults over 65 take doubled between roughly 1990 and 2010. And my sense is that, to 4, and my sense is that number is still going up. What's the danger of too many prescriptions? Most prescriptions are taken by folks over 65. What's the downside of over-prescribing? Because you as a geriatrician are dealing with it every day, but not with many of us with aging parents may not realize that based on those wonderful ads on TV where people are leaping through flower-filled fields and they look on great dates, what could go wrong with just doubling prescriptions and increasing the number of prescriptions for elderly folks or folks over 65 as they get older and just add more subscriptions? What's the problem there?
Well, we could look at this from a number of perspectives. One, of course, is just the patients have to become sort of these little miniature pharmacists where they bring all these medications home. And of course, the medications, some are once a day, some are twice a day. There's a cognitive burden that comes with trying to figure out how to take all these medications at one time. So that's sort of one bucket. A closely related bucket is their out-of-pocket expenses on those medications. Naturally is at the forefront of their thinking. But I think as we get into kind of the whole pharmacologic part of this too, that with each additional drug, the probability of a serious drug-drug interaction really begins to become quite significant. And not only in terms of medications making other medications less effective, but also the potential for side effects. And as we also look at adults as they're getting into the age when they begin to experience some cognitive decline, some of these side effects really play hard on their ability to think clearly, to remain safe. Some of these make them unsteady and predispose them to falls, and falls is a quick rabbit hole that leads them to losing their independence and having to move out of their home. So it's not just merely kind of an academic exercise to try to optimize medications. Medications can really lead to fairly substantial downsides for patients that are often not discussed when they're being prescribed.
So I think really the message is that more medicine really can make us sick. And that's why the de-prescribing isn't anti-prescribing. It's really right-sizing the prescribing as I understand it.
Right sizing is a great way to frame this, because otherwise people get very defensive about it. The prescribers, in other words, get very defensive about this. And patients really scratch their heads about this too. That doctor seemed like a good doctor, that nurse practitioner seemed like a good nurse practitioner. They wouldn't have prescribed something I didn't need or could make my other conditions worse.
There's a couple of really interesting points that you've brought out that I think people may be generally familiar with the idea that seniors maybe have too many prescriptions, but there's a few things, we talk about drug-drug interaction. There's another point you raised about doctor-doctor interaction and, one feeling concerned about that they're going to be undermining their colleague if they de-recommend something that was already there. The idea of electronic medical records not being the place where all of the truth is, and then bed reconciliation occurring in the context of the EHR versus what's really actually happening on a day-to-day basis. And then you raised hospice, where the appropriate de-prescribing is occurring. Could also, when someone takes away a prescription and does the de-prescribing, it could very well give the patient or a family the sense that maybe they're headed toward hospice or someone's giving up on them. To me, those are all big concepts.
Yeah, I couldn't agree more that the language that's used around this process needs to not just be, I'm going to cut your meds from 14 to 10, rather that it's a mutual process. If you think about medications certainly from the patient standpoint, there's medications that help them with symptoms that they experience every day, like arthritis. Those ones they're very protective of making changes to. Then there's other ones that maybe they're being treated for acute or chronic illness, say diabetes or chronic lung disease, and those sort of have at least a tangible benefit that they can put their finger on. But when we get into things like treating hypertension and cholesterol that don't make them feel any different, that becomes kind of a different ball game, and something that we often think about as an afterthought in the de-prescribing conversations are supplements. Consumer Reports does a really good job talking about the challenges around supplements, the fact that these are not FDA regulated, and yet I certainly in my professional life have turned cartwheels trying to get patients more affordable medications, only to find out that they're spending a considerable sum out of pocket on supplements, and so they care a lot about the supplements too, and often they're out of the eyesight or the electronic health record for the professionals can see. And so this is, I think what the point I'm trying to drive at is that from the patient standpoint, they don't view their medications the same. They have different relationships with their medications, and probably from the professional standpoint, just the act of figuring out through a brown bag session or what have you, what medicines are on the table here and beginning to go through them. It's a lengthy process that most clinicians will say, I don't have time to do. And then you say, well, maybe, yeah.
They're not paid for it. I mean, I think one of the interesting things you point out is that folks with chronic illness are likely to see more than one doctor, that the EHR, the electronic health record, which is a record, but not necessarily the comprehensive record of even of drugs, and would never have included supplements unless it's an extraordinarily new one. And that there's a role for the pharmacist that's not necessarily the one that the doctor plays. And that from a patient perspective, you can't, I don't think it's logical to expect that your doctor is going to necessarily be able to take the time or necessarily even have the expertise to understand if you're taking those 4+ meds that a lot of folks over 65 are taking necessarily for your age and your condition wouldn't have contraindications even among themselves, let alone creating other problems. And that it's almost like after every first prescription, there almost ought to be a warning sign, of focus, of sort of recheck, so that make sure that you're not recommending de-prescribing for everyone, but right prescribing, which in many cases may lead to de-prescribing for many.
Yeah, there certainly is a little bit of a fearlessness that goes into this as well, and you come up through the ranks in the geriatrician training pathway, and you're pretty bold and fearless. You sort of have seen so many patients have medication related problems that you're like, I believe that what I'm doing is sort of beneficial, and I'm going to engage the patient family in this process. But so many other clinicians, it really feels like, well, if something goes wrong, it's on me. And then here you have these electronic health records that will ping you about potential drug-drug interactions, but most of the time they're on the most trivial things. So naturally, over time, people start to just ignore them out of hand. Pharmacists are also pretty brave and bold when it comes to this, and we start thinking about annual Medicare wellness visits. This is a role that a pharmacist could play. But of course, a lot of pharmacists out there are employed by pharmacies and things, and so there's a little bit of maybe discomfort about, is that the role of the pharmacist when you're being paid by the pharmacy that wants to see people on many medications? So there are those little twinges that go into it as well, but it's not sort of for the faint. To go in and start de-prescribing and coming up with a right prescribing list, as we're saying, creates a fair amount of anxiety among professionals.
Hey, can we talk about who all these senior citizens are? I remember when I met John, he was about 30, and that was my definition of an old person. Now, that was a while ago. Now I'm over 30. So I think that's, whoever I am is, middle-aged at the oldest. But John, who are these seniors? We talk about, someone turns 65, all of a sudden they're a senior. Now there's people living a long time. Eric, how do you think about kind of these different age bands, or, is it all individualized? Is age just a number? Or, do we need to have some new definitions about what it means to be a senior?
Yeah, I think when we're thinking about population health and planning, that just chronologic age is not necessarily terribly advantageous. So, we think about people in their children or 20s or 30s or 40s much more homogenous than people in their 70s, 80s, and 90s. It's very hard as people get older to make generalizable statements. So typically what we say is, let's talk about functional status as a better proxy for planning population needs and this demographic imperative. But we've been talking about this, baby boomers kind of moving into the ranks, obviously, for 40, 50 years now. We've taken very little action as a country in terms of preparing for this. We point out that it's coming, and yet we're really not in a position necessarily to have anything resembling a national game plan for what it means to support these people, especially as they begin experiencing challenges that make it hard for them to live in the community.
Well, I also think we have a perception problem. I think that, one of the things that defined age when things like Social Security Act and let's go back to that. In 1930, I believe the average lifespan for a man in the U.S. was about 58. Now it's about 78. It's even higher in some of the other parts of the world where they've got healthcare systems that work. And I think that functional status thing becomes, or evaluation becomes absolutely critical. But I do think I don't think our society has yet adapted, certainly in terminology, because over 65 is still considered, elderly. And it really is, what functional status and activity and a whole series of other things. But Eric, for those who kind of don't live in the world of geriatrics or care, how would you describe functional status?
Yeah, so there are wonderful tools out there, but I think just conceptually, we talk about the ability to meet your daily needs. Can you get up in the morning? Can you get out of bed? Can you get to a toilet in time to meet your needs? Can you feed yourself? These are sort of the activities of daily living. And then there's sort of a next level of function that says, if you needed to, can you get your groceries? Can you pay your bills? Sort of really what it takes to support independent living. And by and large, if we look at people, say 65 to 74, only about 1 in 25 struggle with those. If we get to 84, it's more like 1 in 4. And so I don't mean to discount that age is not important. But I'd also point out that 3 out of 4 people over 84 are actually able to do most things for themselves. But those who do need our help are finding that there's not a lot of options out in the community for that. And then not having those options obviously impacts not only on their quality of life, but also on whether they're able to participate in their healthcare, taking their medications, going in for tests, doing all those things where the interface between living in the community and getting your healthcare needs met falls into.
Hey, another interesting area is technology and what's the impact on older people. I remember seeing something years ago that was called like My First Sony, and I remember people saying, "I should give me my last Sony." It was some other kind of a thing. And sometimes you see these really dumbed down technologies for older people, but it also seems like there's some things out there that could be really useful. Like I think about sometimes about like self-driving cars. You talk about taking away somebody's keys, somebody's driver's license, and it's a real loss of independence. But if they could get into their Tesla and be driven around, it could make a big difference. Are these things reality, or is tech, a bunch of hype for the older folks?
There have been different waves of this. There was a really big push in the 90s to create these homes that were smart homes. I don't know if that was the terminology they used, but where the bed weighs you and the refrigerator can automatically order groceries, and there were cameras throughout the house, and you could really make sure that mom or dad was safe living in the community. And if there is a recurrent theme when it comes to technology and older adults, it's that no one seems to have the gumption to talk to older people first. So it turns out older people don't like to have a lot of cameras in their house and having their bed weigh them and have their urine checked and all that. That they found this to be not necessarily compatible with how they chose to live. Now, obviously, there is going to be some cohort effects, and as people are around more technology and become more likely to embrace it. But I think if there is a rule of thumb over the last 30 years of this interface, it's when in doubt, talk to the people that you're creating solutions for, and maybe even better, think about co-designing with them. Because I bump into people at conferences, or people reach out to me and they want to share some new technology, and I'm not sure if they want my blessing or what they really want, but I'll often say, so how many people did you share this with as you were doing the prototyping? And usually it's, I don't know, I just thought this up in my spare time, or worse, any conversation that starts off with, I was making a dinner reservation the other day online. It occurred to, stop. No, there's nothing in healthcare that's as easy as making a dinner reservation. So let's just take that off the table.
So stepping back a little bit from that, Eric, what's we've got this huge age wave of boomers. And do you think the healthcare system is ready with a geriatric approach, which is kind of a whole patient approach to kind of care for this looming and increasing wave of boomers?
Yeah, I think we can probably learn a lot from the last 5-6 years on the healthcare sort of becoming more participatory in the social determinants of health. I think there have been certainly some stories that are worth applauding out there, actions are worth applauding, but by and large, the response has been great. We'll screen these people and we'll make referrals to the community. And that has value. I'm not taking anything away from it. But at some point, it's very easy to overwhelm the very meager community resources that, of course, have always been the stepchild to the big healthcare mega institutional resources that we invest. And so I sometimes pause a little bit about referral to community resources are great. So you can imagine a social determinants of health analogous way of screening for older adults who are experiencing problems and then making referrals to community agencies. Well, that's certainly why we have area agencies on aging. That's a good use of resources. But as you point out, the demographic challenges embedded in this are going to overwhelm what we currently have very quickly. So I feel like healthcare needs to step in a little further than just I'm going to make a referral to this person to get Meals on Wheels.
But I've got to think that particularly in the time of a pandemic, with so many people out of work, that just thinking about hunger as an input for seniors and potentially creating health risk is still something could easily be overwhelmed with. I think it was 7 million people came off of benefits last month. I've got to think that as we go from social determinants to social necessities, or social determinants to personal necessities, that we've got gaps for those referrals to really, if we're truly going to help seniors, or frankly all of us, heal at a time when so many people are hungry.
Yeah, no, I couldn't have said it better than you did, John. And I think what your point illustrates is that it's one thing to sort of talking about older adults who need access to a very expensive and the cutting edge of technology in healthcare, but as you've described, a lot of these folks really need some of the basics, and we're not doing very well covering those basics. I think that the underlying strategy that perhaps from federal policymakers is that if we can align some of these, community organizations that don't have a very strong voice and don't necessarily command the same respect as the hospitals and health systems and the large Medicare Advantage programs, then maybe that sort of all boats will rise. But there are some sort of questions about scope and questions about attention span. Healthcare wants to just keep going after the next shiny object, and whereas this is kind of day in, day out, slug it out, making sure people have basic needs met. It's not as sexy. It's not great for shareholder meetings. There are some inherent conflicts.
Well, I think one of the things I love about you, Eric, is you always remind us how important the unsexy essentials are to driving the sexy results in healthcare. And
I'm always reminded of the unsexy, John, whenever I speak with you or I see your photo. But I do like the back to basics approach, and I think the idea of going back to the acoustics and unplugging the computer and printing up a few de-prescription pads. Those are going to be my takeaways from today's Care Talk. So I think before we get under anyone's skin any further, I'm just going to say that's going to be it for this edition of Care Talk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for listening.